So, a very good morning to all of you. Today, the topic that we are going to discuss is gingiva. So, before we start with our presentation, I would like to welcome you all to the third year of your BDS life. Now, speaking about this topic, gingiva, here I am going to be taking this topic into three parts, wherein I will be talking first about the anatomy of gingiva, taking you to the histological aspects, and finally concluding it with the clinical features of gingiva, the normal features of your gingiva. So before that, what we need to understand, since it is completely a new branch for you, first you need to know what is periodontology and what is periodontics. So periodontics per se is a branch of dentistry which deals with the diagnosis and treatment of disease and conditions of the periodontium. So basically, when we are talking about periodontics, we are dealing with the diagnosis, we are dealing with the clinical aspect of perio. While when we say periodontology, then it becomes a branch of dentistry which deals with this scientific study. See, anything which has an attached logic to it becomes a scientific study, whether it's biology, physiology. So likewise, periodontology is also a branch of dentistry that deals with scientific study of the periodontium in health and disease. Okay. Now, if you know these popular actresses, there is really no requirement of an introduction. You see their beautiful smiles, but you also observe that along with the beautiful smiles, what is common amongst these three pictures is that they have a healthy gingiva also. So it is not always that you need to have a bright and shiny smile compromising your gingiva. You need to make sure that you have a healthy gingiva too. So that is why that makes this topic more interesting and important. So now the definition of gingiva. So this is very, very important. It has been taken from your standard textbook of Carranza. It says the gingiva is that part of the oral mucosa that covers the alveolar processes of the jaws and surrounds the necks of the teeth. Very simple to understand. It's that part of the oral mucosa. So it's a part of oral mucosa which covers the alveolar processes. You will understand what alveolar processes are once I talk about alveolar bone. So it covers the alveolar processes of the jaws and surrounds the necks of the teeth. This definition you really need to remember whenever a question on gingiva is asked in your examination. Now, there are certain reference books. I really thought that you should know that there are certain reference books that you need to refer to while you are studying the subject of periodontology. So basically it is Carranza, which is at your level very important textbook. At postgraduate levels, the number of textbooks increases. But at your level, you need to know these three must to have books. So these are nothing but Carranza's various editions. This is the latest one, which is a 13th edition. While these two are the Southeast Asia edition. This is the second Southeast Asia edition, and this is the third Southeast Asia edition. I will say you can have any of the three books, but prefer having the second South Asia edition because this is more comprehensive and easy understandable textbook. Otherwise, you can have the best is you should have edition 10th or edition 11th. Okay, so now anatomically, gingiva is divided into three parts. You have marginal gingiva, attached gingiva, and interdental gingiva. Now, what is what? Let's see. So this is the gingiva which is surrounding exactly your tooth surface, covering it around the necks of the teeth. This is your marginal gingiva. Okay, so marginal gingiva or the unattached gingiva is the terminal edge or border of the gingiva surrounding the teeth in a collar-like fashion. Clear to understand, crisp to understand that it is basically the unattached form. So what is unattached? It is not completely attached to the periosteum, the underlying bone, rather it is free. Okay, so it is the terminal edge or border of the gingiva surrounding the teeth in a collar-like fashion. You can understand like how your shirt collars are. Likewise, the gingiva is also surrounding the tooth. Okay. Next, you have free gingival groove. So before we come to free gingival groove, let's first talk about attached gingiva. Now, you know what is marginal gingiva here, right? Next, you have attached gingiva. So this is continuous with the marginal gingiva. It is firm, resilient, and tightly bound to the underlying periosteum. Unlike marginal gingiva, which was unattached, attached gingiva is firmly bound to the underlying bone. The facial aspect extends to the relatively loose, movable alveolar mucosa. This is the facial aspect. What you're seeing right now on your screens, on your presentation, in the photograph, is your facial aspect. We are not talking about the palatal, which is behind. So this is the facial aspect. This extends to the relatively loose alveolar mucosa. This is the alveolar mucosa. This is very loose. Okay, you can see the color differences also. So now you've understood what is attached gingiva, what is marginal gingiva. Let's come back to the free gingival groove. So free gingival groove is a shallow linear depression that demarcates marginal gingiva from the attached gingiva. Now this is seen in only 50% of the cases, and if at all present, it will be 1 millimeters wide. So this is the free gingival groove. Don't confuse with marginal gingiva and free gingival groove. Though the wavy patterns are same, but as I said, it is seen only in 50% of the cases. Hence, this is just a landmark to differentiate between marginal and attached gingiva. Okay, so it will be like a depression, like a groove it will be. Next, you have gingival sulcus. So gingival sulcus is a crevice or a space around the tooth bounded by the surface of the tooth on one side and epithelium lining the surface of the gingiva on the other side. So you can see the photograph. This is the instrument which has been kept here is called periodontal probe. It has certain markings here. This will be discussed in your further classes. So when you put a probe across the pocket, you can see the probe is able to deflect the gingiva here. This is the marginal gingiva, right? So this space here, which you can see, this is the space which is bounded by the surface of the tooth on one side and epithelium on the other side. So this is your gingival sulcus. If you see on a histological section, you will find it out. It is V-shaped, and the depth has been reported to be 1.8 millimeters, ranging between 0 to 6 millimeters. This is histologic sections, mind you. We are not talking about clinical probing depth. Whenever a question is asked to you about histologic probing depth, then you have to write it as 1.2 millimeters average, ranging from 0 to 6 millimeters. But when a question is asked, what is the clinical probing depth? That means on chair side, when you're inspecting the patient, what will you find as a normal probing depth? That will be 2 to 3 millimeters. Okay. Next, a little bit about the development. Since you already have a fair idea about the tooth development procedure from your first year onwards, I hope that this is not going to be much troublesome for you. So after enamel formation is complete, enamel is covered by reduced enamel epithelium. REE is reduced enamel epithelium. So once enamel formation is complete, it is covered with reduced enamel epithelium. Now when the tooth penetrates the oral mucosa, you know, when it is erupting. So when it is penetrating the oral mucosa, this reduced enamel epithelium unites with the oral epithelium and changes into junctional epithelium. It's like, you know, it's like fusion of two things. You have REE, that is reduced enamel epithelium. This is getting fused with the oral epithelium and changing its form entirely to junctional epithelium. Now, as the tooth erupts, this united epithelium, just go with the flow, okay? As the tooth erupts, this united epithelium condenses along the crown and the ameloblasts gradually become squamous epithelial cells. I'm repeating this. Once enamel formation is complete, it is covered by a reduced enamel epithelium. When the tooth is trying to erupt, it is getting fused with the oral epithelium and transforming into junctional epithelium. And as the tooth erupts, this united epithelium condenses along the crown and the ameloblast gradually becomes squamous epithelial cells. Okay, we have seen this. Now, width of attached gingiva is the distance between, again, this line is very important and it has been taken from your textbook of Carranza. Width of attached gingiva is the distance between the projection on the external surface of the bottom of the gingival sulcus or periodontal pocket. You have to remember this. Width of keratinized gingiva also includes marginal gingiva. When we are talking about, if in a clinical scenario question is asked, what is the width of keratinized gingiva? Then you have to say that it is from the marginal gingiva right across the attached gingiva. That is your keratinized gingiva width that you have to measure using periodontal probes. In your clinical sites, you will be taught everything. So boundaries of gingival sulcus. Now, what are the boundaries? You know, if you remember, I said it's a V-shaped sulcus. Sulcus is V-shaped, right? It is bounded by tooth on one side and epithelium on the other. Again, it is a true thing. This is a tooth surface. This is the epithelium. Okay. So boundaries again will be what? The same thing in the definition itself. So sulcus is coronal to the attachment of junctional epithelium. This is the junctional epithelium. So junctional epithelium is where the tooth and the epithelium is attaching. That is the junction. Now, it is bounded by the tooth on one side and sulcular epithelium on the other side. Remember, I said epithelium on the other side, so that epithelium is nothing but sulcular epithelium. Again, when I will be talking about histological aspect, I will be speaking on that as well. The different types of epithelium. So that is the boundary. Width of attached gingiva. Now, this is again very important. You need to know the widths, various applicable attached gingiva widths. Like in maxillary incisor region, it is 3.5 to 4.5 millimeters. In mandibular incisor region, it is 3.3 to 3.9 millimeters. In maxillary premolars, it is 1.9, so on and so forth. So you need to remember all these. You need to really mug up all these values, right? Width of attached gingiva increases with age and in supra-erupted tooth. Again, a very important point that needs to be highlighted. Width of attached gingiva increases with age and in supra-erupted tooth. Palatal surface of the attached gingiva in the maxilla blends imperceptibly with equally firm and resilient palatal mucosa. See what happens in the palatal aspect? You do not have anything called as marginal gingiva as such. Okay, so there the palatal surface of the attached gingiva is blending directly with your, you do not have any alveolar mucosa as such there. You don't have any loose tissue there. So there the attached gingiva is binding equally with the firm and resilient palatal mucosa. In the facial aspect, you have alveolar mucosa. In the palatal aspect, you have palatal mucosa. But the difference here is alveolar mucosa is too loose, while palatal mucosa is very firmly bound. And attached gingiva and alveolar mucosa are tightly engaged with each other. Next, we have seen so far marginal gingiva. We have understood about attached gingiva. We have understood about the sulcus, the boundaries of sulcus, development of the gingiva. Now we are going to see interdental gingiva. Now this occupies, now this what space here, can you see this? All this space here, this is all interdental gingiva. So it occupies the gingival embrasures, which is the interproximal space beneath the area of tooth contact. See, what is tooth contact area? Now can you see this? This is your lateral incisors. This is a central incisor. This is the area of contact here. I'll just enlarge the slide. Okay. So this is the area of tooth contact. So interdental gingiva occupies a gingival embrasure, which is the interproximal space beneath the area of tooth contact. This is the area of tooth contact. So just below that will be the interdental gingiva. This can be pyramidal or cone shaped. It will be pyramidal in the anteriors, while cone shape will be present in the posteriors. In the pyramidal, the tip of one papilla is located immediately beneath the contact point. Like this, the anterior, as I said. Okay, so the tip of the papilla is located immediately below the contact point. That is your pyramidal. Cone represents a valley-like depression. You can see this is the mesial aspect of the gingiva. This is the distal. Sorry, this is the facial aspect of the gingiva, and this is the palatal or lingual if we are talking about mandible. Then this represents the valley-like depression, that is the cone-shaped gingiva, which is present in the interdental papilla in case of a posterior tooth. Okay. So the shape of gingiva in a given interdental space depends on The space of the gingiva in a given interdental space depends on the contact point between the two adjoining teeth and the presence or absence of some degree of recession. The facial and the lingual surfaces are tapered towards the interproximal contact area, whereas the mesial and distal surfaces are slightly concave. So the shape of your gingiva in the interdental space very much will depend on the contact point. If there's no contact point, like in this case, no contact point because of diastema or something, that will govern the shape of your interdental gingiva. Now, lateral borders and the tips of interdental papilla are formed by marginal gingiva of the adjoining teeth. Intervening portion consists of attached gingiva, and if a diastema is present, as in this case, if a diastema is present, gingiva is firmly bound over the interdental bone and forms a smooth, rounded surface without interdental papilla. So in this case, it is flat interdental papilla. See, right now what I'm dealing is with the normal features of gingiva. We will be speaking on clinical features of gingivitis as a separate chapter and a separate topic itself. So for now, you need to understand what is the normal gingiva. Only when you understand what is normal, you will be able to differentiate what is abnormal. Okay. So with this, we have covered our first part, which is anatomy of your gingiva, wherein we have learned about the various parts of gingiva, how anatomically they are divided, and what is their significance. Now we come towards part 2, which is microscopic features. So microscopic examination reveals that gingiva is composed of stratified squamous epithelium. If you remember the development, there was a mention about the stratified squamous epithelium, how it is formed, right? So microscopic examination reveals that gingiva is composed of stratified squamous epithelium and the underlying central core of connective tissue. Epithelium is predominantly cellular, whereas connective tissue is less cellular, contains more collagen and ground substance. Now, microscopically, gingiva is divided into gingival epithelium and gingival connective tissue. So first we start with connective epithelium. So epithelium is always the first layer. If you see your hand, you have epithelial surface. Okay, you have epithelium, endothelium, then you have connective tissue. Same ways in gingiva also you have epithelium and then connective tissue. So epithelial cells plays an active role in the innate host defense by responding to bacteria in an interactive manner, which means the epithelium participates actively in responding to infection, in signaling further the host reactions and in integrating innate and acquired immune responses. The gingival epithelium consists of a continuous lining of stratified squamous epithelium, and the three different areas can be defined from the morphologic and functional points of view. Now, gingival epithelium, as I said, I will be speaking in microscopic examination. What are the three types of epithelium? So you have an outer or oral epithelium, you have sulcular epithelium and junctional epithelium. So the principal cell type of gingival epithelium as well as other stratified squamous epithelia is a keratinocyte. The other cells found in the epithelium are the clear cells or the non-keratinocytes, which includes Langerhans cells, Merkel cells, and melanocytes. I have marked this for you. So please remember this. This comes as a very important MCQ. That what is the principal type of gingival epithelium? So it is a keratinocyte. So the rest of the cells are called as non-keratinocytes, which includes Langerhans cells, Merkel cells, and melanocytes. The main function of gingival epithelium is to protect the deep structures while allowing a selective interchange with the oral environment. This is achieved by proliferation and differentiation of the keratinocytes. Please understand that what is proliferation and differentiation? Proliferation is increase in the number. Differentiation is how specialized they are. Okay. So with the help of proliferation and differentiation of the keratinocytes, the gingival epithelium is able to protect the deeper structures while allowing the selective interchange. So this happens because of proliferation and differentiation of the keratinocyte, which is the principal cell type of gingival epithelium. This is another functions and features of gingival epithelium, which has been taken from your textbook of Carranza. You can just very well go through your textbook and try to understand that. Now, proliferation of keratinocytes takes place by mitosis. I'm pretty sure you know what is mitosis and meiosis. I'm not going to go much into detail of that. So proliferation of keratinocytes takes place by mitosis in the basal layer and less frequently in the suprabasal layers, in which a small proportion of cells remain as a proliferative compartment, while a large number begin to migrate to the surface. All right. Now, if you see the layers of the epithelium, there are 4 different layers, starting from stratum basale, going up to spinosum, granulosum, and corneum. This is the topmost layer. So differentiation involves the process of keratinization, which consists of progressions of biochemical and morphologic events that occur in the cell as they migrate from the basal layer. Main morphologic changes are progressive flattening of the cell with an increasing prevalence. What are we discussing here? The main morphologic change. That means right from the basal, here is where the cells are being produced. So right from basal up to spinosum, granulosum, corneum. Once the granules move, what are the various morphologic changes taking place once they are moving from the bottom layer to the topmost layer? There is progressive flattening of the cell with increasing prevalence of tonofilaments, intercellular junctions coupled to the production of keratohyaline granules, and disappearance of nucleus. A complete keratinization process leads to the production of orthokeratinized superficial horny layer similar to that of the skin, with no nuclei in the stratum corneum and a well-defined stratum granulosum. So when a complete keratinization takes place, it leads to the production of orthokeratinized layer. In parakeratinized epithelia, the stratum corneum retains the pycnotic nuclei. See, this is the stratum corneum. Right now, what we learned here is the main morphologic features. We saw that there's a disappearance of nucleus. Right now, if the stratum corneum is able to retain some nuclei, that is a pycnotic nuclei, and the keratohyalin granules are dispersed, it does not give rise to stratum granulosum, and hence the epithelia is parakeratinized. Then you have non-keratinized epithelia, which has neither a granulosum layer nor a corneum strata. So these both the stratas are missing. In parakeratinized, only stratum granulosum layer is missing, while in orthokeratinized, both of these layers are missing. And in parakeratinized, granulosum is missing. Non-keratinized, both of these are missing. And orthokeratinized, you will have all the four layers. Okay. Now, the uppermost cells of the stratum spinosum contains numerous dense granules called keratinosomes or Odland bodies. Again, an MCQ question, that's why I have marked it. So the uppermost cells of the stratum spinosum contains numerous dense granules called as keratinosomes or Odland bodies. Then you have melanocytes. Okay, these Odland bodies are modified lysosomes. Again, an important MCQ question. Sometimes they ask, what is the other name of the modified lysosomes present in the stratum spinosum? So these Odland bodies also contains acid phosphatase, an enzyme which is involved in destruction of organelle membranes. Then melanocytes. Melanocytes are dendritic cells located in the basal spinous layer, that is the stratum basale. Okay, they synthesize melanin in the organelles called pre-melanosomes or melanosomes. Okay, so melanocytes is responsible for your melanin production. Not exactly, but they are stored, they synthesize melanin, which is an organelle stored in pre-melanosomes, right? So they contain tyrosinase, which hydroxylates tyrosine to produce dihydroxyphenylalanine, that is DOPA, which in turn is progressively converted to melanin. Melanin granules are phagocytosed and contained within other cells of the epithelium and connective tissue called melanophages or melanophores. Langerhans cells are also dendritic cells. Just like melanocytes, they are also dendritic cells located among keratinocytes at all suprabasal levels. Langerhans cells have a very important role in immune reaction as antigen presenting cells for lymphocytes. You must have come across this term in your physiology textbook, antigen presenting cells. So they contain G-specific granules, also known as Berbeck's granules, and have marked adenosine triphosphatase activity. They are found in oral epithelium of the normal gingiva and in smaller amounts in the sulcular epithelium. They are probably absent from the junctional epithelium of normal gingiva. Merkel cells. Now we have spoken about your melanocytes. We have dealt with Langerhans cells. Now Merkel cells. Now they are located in the deepermost layers of the epithelium and they harbor the nerve endings. You need to just remember this much at least. That they harbor the nerve endings and they are located in the deeper layers of your epithelium. Now, epithelium is joined again. So with this, if you see, we are coming towards connective tissue now. We have almost completed epithelium. Now, epithelium is joined to the underlying connective tissue by a basal lamina, which is 300 to 400 angstrom thick. Okay. Just directly after epithelium, you do not have connective tissue. There's a basal lamina also in between the connective tissue and the epithelium. This basal lamina contains two layers, lamina lucida and lamina densa. Lamina lucida is more towards the epithelial surface, while lamina densa is more towards the connective tissue surface. Hemidesmosomes of the basal epithelial cells above the lamina lucida, which is mainly composed of glycoprotein laminin. Lamina densa is mainly composed of type 4 collagen. Yeah. You need to understand the structural and metabolic characteristics of different areas of the gingival epithelium. The oral epithelium or the outer epithelium, they cover the crest and outer surface of marginal gingiva and the surface of attached gingiva. On an average, the epithelial thickness is 0.2 to 0.3 millimeters. It is keratinized or parakeratinized or presents various combinations of these conditions. The prevalent surface, however, is parakeratinized in oral epithelium. Okay. Circular epithelium is non-keratinized. See, oral epithelium is parakeratinized. Prevalent surface, however, is parakeratinized. It can be keratinized or parakeratinized, but mostly it is parakeratinized. And if you remember, what is the layer which is missing in parakeratinized? It is stratum spinosum. Oh, sorry, granulosum. Granulosum is the one which is missing. Sulcular epithelium lines the sulcus and it is non-keratinized. That means it does not have granulosum, nor it has corneum. So it is thin, non-keratinized, stratified squamous epithelium with retipex. Sulcular epithelium is extremely important because it acts as a semi-permeable membrane through which injurious bacterial products pass into gingiva and tissue fluid from the gingiva seeps out into the sulcus. Unlike junctional epithelium, not heavily infiltrated by PMNs. PMNs is polymorphoneutrophils. So junctional epithelium has maximum amount of neutrophils. Junctional epithelium has maximum amount of neutrophils and sulcular epithelium does not have that much. Junctional epithelium is non-keratinizing epithelium. Remember this. Okay, it is a non-keratinizing epithelium. It is 3 to 4 layers thick in early life, but the number of layers increases with the age to 10 or even 20 layers. Junctional epithelium tapers from its coronal end, which may be 10 to 29 cell wide to 1 to 2 cells at its apical termination. So it's the cells are narrowing down. It's tapering. It's tapered basically. These cells can be grouped into two strata: basal layers facing the connective tissue and the suprabasal layer extending to the tooth surface. Length of junctional epithelium, again very important MCQ question. Length of junctional epithelium is 0.25 to 1.35 millimeters. Junctional epithelium is attached to the tooth surface by means of internal basal lamina, and it is attached to the gingival connective tissue by means of external basal lamina. So junctional epithelium has two attachments. One is towards the tooth and one is towards the connective tissue. Towards the tooth, it is internal basal lamina. Towards the connective tissue, it is external basal lamina. Then dentogingival unit is very important. I'm so sorry. So the attachment of junctional epithelium to the tooth is reinforced by gingival fibers. Reinforced, what do you mean by reinforced? It is recapitulated, made more strong. That is what is reinforced. When you come to clinics, you will come across terms like reinforcing oral hygiene instructions. That means you're making the oral hygiene instructions more strong in the patient's head. So attachment of junctional epithelium to the tooth is reinforced, further strengthened by the gingival fibers, which braces the marginal gingiva against the tooth surface. That is the reason the junctional epithelium and the gingival fibers are together considered as a functional unit and hence called a dentogingival unit. Okay. Now, you can leave this. Okay. Renewal of the gingival epithelium. See, oral epithelium undergoes a continuous renewal process. Its thickness is maintained by a balance between new cell formation in the basal and spinous layers and the shedding of old cells at the surface. Mitotic activity exhibits a 24-hour periodicity with the highest and the lowest rates occurring in the morning and evening. So continuous shedding of the epithelium takes place. Old epithelial layers are being shed out and replaced by the new ones. Okay, and there is a 24-hour periodicity to this procedure. Highest happening in the morning and lowest in the evening. Regarding junctional epithelium, it was previously thought that only epithelial cells facing the external basal lamina were rapidly dividing. However, evidence now indicates that a significant number of cells, such as the basal cells along the connective tissue, are also capable of synthesizing DNA, demonstrating their mitotic activity. So earlier it was thought that junctional epithelium, which is facing towards the connective tissue, was the one which is rapidly dividing, but now evidence indicates that the cells which are facing towards a tooth structure via means of external basal lamina also has the capacity to synthesize DNA, hence demonstrating their mitotic activity. Rapid shedding of the cells effectively removes bacteria also, which is adherent to the epithelial cells and therefore is an important part of the antimicrobial defense mechanisms of the dentogingival junction. Now, with this, we have covered with our gingival epithelium. Now we move on towards connective tissue. The major components of gingival connective tissue are collagen fibers. Maximum it is collagen fiber, and in that also type 1 collagen fibers. At your level, the most of the questions where we will be asking you, answer per se blindly will be type 1 collagen. You don't have to worry. It is the maximum amount which is present. Then you have fibroblasts, vessels, nerves, and matrix. Connective tissue of the gingiva is known as lamina propria. Again, an important MCQ question. And it consists of two layers. You have papillary layer and reticular layer. Papillary layer subjacent to the epithelium, which consists of papillary projections. Reticular layer is continuous with the periosteum of the alveolar bone. So again, see, you have epithelium, you have connective tissue, and then after that you have alveolar bone. So this papillary layer of the connective tissue is facing towards the epithelium, while your reticular layer is facing more towards the bone. Connective tissue has both the cellular and extracellular compartments composed of fibers and ground substance. So ground substance fills the space between the fibers. You have fibers are like threads. So between these threads, you have certain spaces which is filled by the ground substance. It is amorphous and has high content of water. It is composed of protoglycans, hyaluronic acid, chondroitin sulfate. Three types of connective tissue fibers are collagen, reticular, and elastic. These are the three types of connective tissue fibers: collagen, reticular, and elastic. And collagen type 1 forms a bulk of lamina propria. That means your connective tissue. Now, speaking of the fibers, we just spoke the wavy nature of fibers. In between the fibers, there are ground substance which is occupying the free space. So now, how are these fibers and what are the types of fibers? So connective tissue of the marginal gingiva is densely collagenous, containing a prominent system of collagen fiber bundles called gingival fibers. Gingival fibers have the following functions. They brace the marginal gingiva. You have heard the term brace the impact, right? In airplane crashes. So what is brace the impact? It is making sure that the injury does not take place too much. So the fibers are bracing the marginal gingiva firmly against the tooth to make sure it is not bruised against anything. Also, it provides rigidity necessary to withstand the forces of mastication. If it was not there, if the fibers were not there, while eating, you would always bruise your gingiva. So they are providing a rigidity also. They are uniting the free marginal gingiva with that of cementum of the root. Right? Marginal gingiva at one portion is only elevated like a flap. Other portion is attached. So they are uniting. The fibers are uniting the free marginal gingiva with the cementum of the root and the adjacent attached gingiva. So these are the various types of fibers. You have sulcular, dentogingival, intercircular, intergingival. I would recommend, I would really want you to please read your textbooks, try understanding the fibers, exactly where they are located. If any problem, we can discuss it in our classes. Okay, coming to the blood supply, lymphatics, and nerve supply. Now there are three sources of blood supply to the gingiva. There is supraperiosteal arteries along the facial and the lingual surfaces. Then there are vessels of periodontal ligament that anastomoses with the capillaries in the sulcus area. And then there are arterioles which emerges from the septa and anastomose with the vessels of PDL and capillaries in the sulcus area. See, there are supraperiosteal arteries. So what are supraperiosteal? Just above the periosteum. So these are the supraperiosteal arteries along the facial and the lingual surfaces of the gingiva. Then you have vessels of periodontal ligament. You have PDL here. So you have vessels of periodontal ligament that anastomoses with the capillaries of the sulcus area. Then there are arterioles that emerges from the septa. This is the bone, septa. So there are arterioles emerging from the septa, anastomosing with the vessels of the PDL and capillaries in the sulcus area. Lymphatic drainage of gingiva brings in lymphatics of the connective tissue papilla. It progresses into the collecting network external to the periosteum of the alveolar process and then to the regional lymph nodes, particularly the submaxillary group. The following nerve structures are present in the connective tissue: a meshwork of terminal argyrophilic fibers, some of which extends into the epithelium, then Messner type tactile corpuscles, cross type end bulbs, and encapsulated spindles. These are the nerve structures. You have to remember this. There's no other option. You have to mug it up. These are the nerve structures present in the connective tissue: argyrophilic fibers, Messner type tactile corpuscles, cross type end bulbs, and encapsulated spindles. Okay, so with this, now we have covered our second part also, where we have spoken about the micro aspect of your gingiva, microscopic features of gingiva, where we spoke about your gingival epithelium in detail, the connective tissue, and your blood supply, lymphatics, and nerve supply of your gingiva. Now we are dealing with the third and the last important topic of gingiva, that is the clinical features of healthy gingiva. Please mind it, it is healthy gingiva. Only, as I said, if you know healthy gingiva, you will be able to understand what is diseased gingiva. Okay, starting with the color. So color of the attached gingiva and marginal gingiva is generally described as coral pink and is produced by vascular supply, thickness and degree of keratinization of the epithelium and the presence of pigment containing cells. So these are the 4 reasons why the gingiva is coral pink. Many a times this question is asked in Viva and you get confused with 1 or 2. So you have to remember all the 4. There are 4 reasons of color of gingiva: vascular supply, thickness of the epithelium, degree of keratinization of the epithelium, and the presence of pigment containing cells. The attached gingiva is demarcated from the adjacent alveolar mucosa on the buccal aspect by a, I'm so sorry, by a clearly defined mucogingival line. Okay. Between the attached gingiva and alveolar mucosa, you have a mucogingival junction. So epithelium of the alveolar mucosa is thin, is non-keratinized and contains no retapex. Oral repigmentation refers to the clinical reappearance of melanin pigment after a period of clinical depigmentation of the oral mucosa resulting from chemical, thermal, surgical, pharmacologic or idiopathic factors. So color of gingiva is coral pink. But this coral pink per se is seen in Caucasian individuals. In Indian population, you have more of pale pink. So when you're writing it as color in your log books, please mention it as pale pink always. Because see, these textbooks were all written by foreign authors, so they have only seen those patients. But we are dealing with Indian population, so we have to be more concise and precise with the Indian population. So in that case, it is pale pink. Then comes the size. So size of the gingiva corresponds with the sum total of bulk of cellular and intercellular elements and their vascular supply. So any alteration in the size, you can see the image. You can see there's some variation in the size. So any alteration in the size has to be noted down under the heading size. If there's an enlargement, you have to mention enlargement present. Then speaking of contour. So the contour or shape of the gingiva varies considerably and depends on the shape of the teeth and the alignment in the arch. The marginal gingiva envelopes the tooth in collar-like fashion and follows a scalloped outline. See, this is scallop. This is scalloping. So healthy gingiva will have scalloping. On teeth with pronounced mesiodistal convexity, like in maxillary canines, the normal arcuate contour is accentuated. Accentuated means it will be more towards apical, but especially in canines. So there you will have accentuated gingiva. And the gingiva is located farther apically. On the teeth in lingual version, what do you mean by lingual version and labial version? Tilt. Lingual version, if this is the tongue here, if the tooth is like this, facing tongue, bent towards the tongue, that is a lingual version. Labial version is more away from the tongue. Okay. So on the teeth in lingual version, the gingiva is horizontal and thickened. In addition, gingival tissue biotype varies significantly. Shape. When you are talking about the contour, you are talking about the marginal gingiva. When you speak about the shape, your mind should directly go towards your interdental gingiva. So shape of interdental gingiva is governed by contour of the proximal tooth surface. So it will. I have mentioned about this when I was discussing about interdental gingiva also, that the shape will be either pyramidal, as in the case of anteriors, or hole shaped or tent shaped in the posteriors. So that is your healthy feature. Consistency. Normal consistency of the gingiva is firm and resilient, and with the exception of movable free margins. So it is firm and resilient. There are 3 types of consistencies. Normal is firm and resilient. Now, can you see that this picture does not show that normal? Is it normal? Is it anywhere firm and resilient? You see bulbous enlargements here. Edematous gingiva, right? So this is not, this is soft and edematous diseased gingiva. I will be speaking on diseased gingiva. I will be taking this clinical features of gingivitis again as a separate topic, either in clinics or as theory. But for now, you remember that this is not firm and resilient. This is firm and resilient, right? You can see the difference. Okay. So that is consistency for you. Surface texture. You will see some orange peel appearance like this. Okay. This is what is surface texture. So the attached gingiva is stippled. When we are talking about surface texture, what we are looking for is stippling, whether it is present or not. So you will find stippling, you will find this orange peel appearance in attached gingiva and the central portion of the interdental papilla, nowhere else. Stippling varies with age and it is absent in infancy, appears in some children after 5 years of age and disappears in old age. Now, microscopically, stippling is produced by alternate rounded protuberances and depressions in the gingival surface. You see that it depicts the connective tissue, the wavy pattern, connective tissue, epithelium, and connective tissue, the retipix. So that rounded protuberances and depressions, how deep it will be, that will define the amount of texture, the surface texture that you will see. So stippling is a form of adaptive specialization or reinforcement for function. It is a feature of healthy gingiva, and reduction or loss of stippling is a common sign of gingival disease. Now, if you see this picture again, can you see there is no stippling present here? It's smooth and shiny, completely smooth and shiny, because the protuberances and depressions have been filled with fluid here. That is why you're not able to see that. So microscopically, stippling produced by alternate rounded protuberances and depressions in the gingival surface. Stippling is a form of adaptive specialization or reinforcement of function. The surface texture of gingiva is also related to the presence and degree of epithelial keratinization. Next is position. So where your margins are located, that is your positions. So according to the concept of continuous eruption, eruption does not cease when the teeth meet their functional antagonists. What are functional antagonists? For a lateral, it is the other lateral on the mandible as mandible. Okay, so it does not cease with their functional antagonists, but continues throughout life. You know, tooth eruption is a continuous process. Active eruption is the movement of teeth in the direction of occlusal plane, whereas passive eruption is the exposure of the teeth by apical migration of gingiva. Very, very important. Active eruption is when the tooth is moving towards your occlusal plane, while passive eruption is when the gingiva is receding down. This concept distinguishes between anatomic crown, anatomic root, clinical crown, and clinical root. So anatomic crown is the portion of the tooth which is covered by your enamel. You know, the tooth portion is covered by enamel, the crown is covered by enamel. That is your anatomic crown. Anatomic root is the portion of the tooth covered by cementum. Clinical crown is the part of tooth that has been denuded of its gingiva and projects into the oral cavity. So what you see here is a clinical crown, but anatomic will be below this because it is covered by enamel. Clinical root is the portion of tooth covered by periodontal tissues. Now this is the stage of eruptions. The teeth reaches a line of occlusion. The junctional epithelium and the base of gingival sulcus are on the enamel. In stage 2, junctional epithelium proliferates. That means it specializes, divides, so that part is on the cementum and part is on the enamel. So 50% on cementum, 50% on enamel. Base of the sulcus is still on the enamel. The entire stage 3, the entire junctional epithelium has come down on the cementum, and the base of the sulcus is also on cemento-enamel junction. In stage 4, junctional epithelium has proliferated further apically towards the cementum, and the base of sulcus is on the cementum, a portion of which is exposed. So this is your eruption, continuous eruption stages. So this is what we see in position of the gingiva, whether it is coronal or apically located. All right. So when you're writing in position, you have to write it as coronally or apically. The terms that has to be used. Right. So with this, we have covered with the topic gingiva. We have spoken about the normal features. We have spoken about how anatomically it is divided. We have seen the histological and microscopic features, and we have also seen the clinical aspect. I hope that you have understood this chapter well enough. And next, we will be speaking on periodontal ligament, which is the next topic in normal periodontium. Further on, after that, we will be speaking on, I'll be taking the topic on cementum and concluding it with the last topic of periodontium, which will be alveolar bone. So thank you so much.